All right. So, let us start with our first set of antibiotics, and of course, we're going to recall, our rules that this is edutainment, and that you are still responsible for fact checking all this, um, and always look at your antibiogram, and then the others. Okay, so where were we? We were somewhere here. And we've just gone through all of the different organisms. And so now let's talk about one of the first steps. So how do we, what are we going to go? And I think, a lot of emphasis on your first year of med school is about learning all the biology and fundamental mechanisms. But, in general, you're probably not going to need to know every last molecular detail when you're generally practicing clinical medicine. But I do think it's helpful to at least remember that there is some underlying mechanism. And so the way we're going to kind of go through these antibiotics are step by step. So what is the first step on our pathway? Well, recall all life on this planet has DNA. So is there some way we can inhibit DNA from forming? And the answer is yes. So there's a very important vitamin that at least, first of all of us need, 100% of humans need this vitamin. And it is important in the formation of the nucleotides or building blocks that make up DNA. It's involved in single carbon transfers. However, half of the people watching, if not now more than half, really need to remember, especially if they're between, the childbearing ages, should be on this vitamin supplement daily, and that is folate. So recall, folic acid is important in the purine biosynthesis, I think pyrimidines do. And it is made in two steps. So microbes. So for us, it's a vitamin. We have to get it from leafy green vegetables, plants, other sources. But bacteria make it in most cases. And so there's a two-step process, or there's a multi-step process, but one of them is the formation of PABA. And then from PABA, it is synthesized into folate, which then needs to be reduced to tetrahydrofolate through multiple steps. And that is the dihydrofolate reductase step, which then converts to tetrahydrofolate. And there is an antibiotic that blocks these two. And what is that antibiotic? That is, you guessed it, trimethoprim. Sulfamethoxazole. Sulfamethoxazole. It is a combination antibiotic made up of trimethoprim, which does in fact block the dihydrofolate reductase, and sulfamethoxazole, which prevents the PABA synthase step in bacteria. It is better known, usually abbreviated as TMP-SMX, or better known as bactrim. Cotrimoxazole is another common name for it. But we are going to avoid brand names, so we are just going to talk about bactrim. So let us go through these things. And like I said, we spent all this effort learning all these different bacteria that are important. So let's actually go through them step by step and see what it covers and then what clinical scenarios might we use them in. So trimethoprim sulfa, what does it work on? Well, let's get a cool pen. Let's use this. Let's try out this Galaxy pen. Let's make it big. All right. Awesome. All right, so does trimethoprim sulfa work on staph? And when I say staph, remember, after this talk, you have to stop saying just staph unless you know what you're meaning. And that staph means Staph aureus. So does trimethoprim sulfa work on MSSA? And the answer is you betcha. It does work on MSSA. And does it work on MRSA? Interestingly, it is a pretty good drug for MRSA infections. And so you can absolutely use it for these infections. Now, interestingly, what about streps? So For a long time, the dogma was you cannot use trimethoprim sulfa for group-based strep infections, and why is that? So when you, especially using older media, when you put when you grew on a plate group-based strep and you put a disc of trimethoprim sulfa down, it would grow. Group-based strep would grow. So we said, it's resistant. But it turns out that one of the interesting things about the media is that it had a lot of free thymidine in it. And when you have a lot of free thymidine, the group-based strep was able to confiscate that or co-opt it and utilize that in its biosynthetic pathway and get around the inhibition that was being brought out by the trimethoprim sulfa. It was able to incorporate it and derive other nucleotides from it. But it turns out that, in the human body or in most animals, that we don't just have a lot of free thymidine just floating around. And so it turns out if you actually use thymidine deficient or reduced thymidine media, you can actually see that in many cases trimethoprim sulfa works. And in fact, there was somebody, I'm blanking on his name, but did a lot of work, I think, in Australia, showing that trimethoprim sulfa was actually working pretty well for group-based strep based impetigo and was having clinical success with it. And why is that? Well, because probably most strep is susceptible. And let me see if I can pull up a reference. Let's see. I think I had it somewhere. Let me see if I can find it. Yeah, okay, here's at least one. Is strep pyogenes resistant or susceptible to trimethoprim sulfa? And the answer is, if you're using this Mueller-Hinton agar, which is where the thymidine concentrations are low, they were actually getting excellent. Let me see if I can zoom in a little bit. They were actually getting great susceptibility rates with uh, sulfamethoxazole. So the answer is, yeah, it probably is susceptible. But do we use it? I think probably everyone's still a little worried. That being said, bactrim is probably, or sorry, excuse me, trimethoprim sulfa is probably okay for the majority of cellulitis infections where you're sort of struggling between group-based strep and Staph aureus in terms of the source. Does it work? So we're gonna put a question mark, but question mark check because probably does work for group-based strep. Interestingly, for pneumococcus, so as a personal story, I when I was a little kid, got a lot of ear infections, and I had a penicillin allergy. So what did I get put on? I got put on a lot of sulfa drug for those ear infections. Why? Because it does in fact work on pneumococcus, but there's a lot more resistance as rates go, and so um, we would say, check with caution, with caution, for pneumococcus. Um, in terms of enterococci, they are very good at scavenging nucleotides and can metabolize them. So the answer is no. In fact, if we think about enterococci as like super strep pneumos, generally you'll be okay with that analogy. So it's not going to work for the enterococci. Now, how about E. coli, Klebsiella, all these gram-negative, Salmonella? Does trimethoprim sulfa work on them? And the answer is kinda. Do it kinda. So back in the day, I mean, the sulfamethoxazole or the sulfa, well, not sulfamethoxazole specifically, but the sulfa drugs were in fact our very first true, proper, modern antibiotic. And they did work for a lot of the gram-negatives, E. coli, Klebsiella, Enterobacter, and they still, in many cases, do work, but resistance is increasing significantly. And so it would not be good for first line. So don't use these for first line. No first line. So if you have somebody coming in with a septic UTI, do not start them on trimethoprim sulfa. That being said, In most cases, or at least in many cases, 60–70% of the time, E. coli, Klebsiella, and you again look at your antibiogram, but you will see quite a bit of susceptibility. So it is pretty good for UTIs as long as you know you've done a culture and you've got your susceptibilities back and you know it's trimethoprim sulfa susceptible, that you can use these. And in fact, similarly, even with non-typhoidal salmonella or even typhoidal salmonella, when it's not resistant and we can grow it and run susceptibilities, you might be able to use it in those situations. Does it work on Pseudomonas? Absolutely not. Generally, you would be very cautious about Acinetobacter. However, interestingly, it is the drug of choice for Stenotrophomonas infection. So again, you can't necessarily always think about these as just, oh, environmental gram-negatives. Trimethoprim sulfa doesn't work. Well, it does on Steno. It's the drug of choice. All right, how about Neisseria? Unfortunately, meningitis, it might, gonococcus, you're out of luck. But Haemophilus, Moraxella, and in fact, Bordetella pertussis as well. It is the second-line agent for use in Bordetella pertussis if you have, for instance, an infant who's allergic or can't tolerate azithromycin. So absolutely can be used in some of these mucosal gram-negative infections, but be careful. Does it work on atypicals? It's not particularly great for atypical infections. Does it work on anaerobes? It's not a particularly effective antibiotic on anaerobes. And how about mycobacteria? Not really. You certainly can't use it for TB. There are a couple NTMs where trimethoprim sulfa can have some activity, but again, not a generally used antibiotic. So, where do we use trimethoprim sulfa? Well, if you noticed, it's a great drug for MSSA, MRSA, and it might even be acceptable in group A strep. So, when can you use it? Cellulitis. And can you even distinguish, another question, of course, is can you distinguish Staph aureus from group A strep? And the answer is in a lot of cases, yes, you can clinically. Staph aureus loves to cause, honking abscesses. So if you get like a big furuncle or, an abscess that's got a lot of pus in it and fluctuant, you can drain it and all that goop comes out. That will typically be MSSA or MRSA. And in fact, probably in this day and age, more likely to be MRSA, especially if you're getting recurrent skin abscesses, because that's what MRSA loves to do. Um, but and can you distinguish strep? Well, yeah, strep tends to be a much more aggressive cellulitis in terms of spreading, especially if you have that really large red patch and you've got that red streaking along those lines. You remember what that is called? That is the lymphangitis or lymphangiectatic spread. And so that is certainly, it's very well demarcated with some swelling. That would be a classic other strep cellulitis called erysipelas. So in those cases, that tends to be group A strep. Not always, nothing's ever 100%, but that tends to look a little bit more like a group A strep infection. And of course, impetigo is the same. It's really hard to distinguish. You have a poor kid with a bunch of crusty red lesions, honey crusted red lesions. That could be either a group A strep or staph, or if you just have some red skin, it can be difficult sometimes. But certainly there is some clinical distinction there. But it is a reasonable antibiotic to start with for cellulitis. Certainly UTI. When you know, only when you know, which means get cultures. I don't know how much we have to scream this as ID physicians, but get cultures. There is no reason not to get cultures. No reason in this world. Get a blood culture, get a urine culture. It tells you everything you need to know. It'll grow the bacteria if it's there, and it'll tell you what antibiotics it's susceptible to. It is 100% something you should be doing basically all the time, unless you have a very good reason not to. So certainly can use for a UTI, and sort of, and we'll put that as sort of like second line or after, and then we can actually use it in infections like sinusitis and otitis media, acute otitis media, again, as sort of a second line agent. It's not going to be your first line But in patients with pananaphylaxis and you need an alternative agent, you can absolutely think about this. Just realize that especially pneumococcus is going to have a decent amount of resistance. So you might not be 100% successful. So if it's something severe, or it's something where you're not going to have good follow-up, or you're really worried for some other reason, then you might need to reconsider or use something else. Okay, but it is an option for those. Uh, and then, of course, if you've got a steno, tracheitis, or ventilator-associated pneumonia, it would certainly be a case. And we said, sort of a second-line agent for bordetella pertussis in infants who can't tolerate certainly is that option too. Okay, so those are some of the clinical uses. So let's just clear this up so I don't ruin all my work. Let's see. Uh-oh. Why are you not undoing? Oh no, did I ruin my whole... Well, all right. Apparently ruined this whole thing, so I'll have to redraw it for the next one. But let's just get back into it. So the next thing we have to think about... Let's try it one last time. No, I have somehow ruined it. Okay, so here and erase. So now not that. Ah, all right. All right, so fortunately it looks like I have ruined my little chart, so I learned from this mistake, and when I redraw it, we will copy it and then paste it. But the next most important thing about any discussion of antibiotics is toxicities. Toxicities. So the reality of medicine is that nothing is free. Every single thing you do can have a side effect, and you always have to be aware of those, because once you start something, you have to think about, when my patient is not responding or something's going wrong, is it something I'm doing? And that is one of the fundamental, I think, principles of medicine is, what have I done to make this worse? So, what are some of the side effects? Probably the most concerning and notorious one with trimethoprim sulfa is the Stevens-Johnson syndrome. This is sort of the big bad wolf of using trimethoprim sulfa. It is very rare. So, you will probably go your whole career, if you are even reasonably using trimethoprim sulfa, without ever seeing a patient who has it. But if you are one of those unfortunate physicians who gave someone trimethoprim sulfa and they had Stevens-Johnson syndrome, you will remember it. And I usually ask med students, well, or in residents, like, what is Stevens-Johnson syndrome? And they'll always say, oh, it's a rash. And I want you to not think of it as a rash, because are the patients sick or not sick? And the answer is they are sick. They can have fevers. They can have hypotension. They can be very sick. It's even got like somewhere around a 5 to 10% mortality if it happens. So I want you to think of it as a systemic inflammatory reaction that has prominent mucocutaneous findings. So remember they're sick. Remember it's a concerning thing. And what are the mucocutaneous findings? Well, of course, those are the most obvious, especially when you have mucosal involvement, like mouth ulcers, sores, cracking, bleeding, conjunctivitis. You can also have urethritis and urethral meatal cracking, vaginal erythema, and perianal erythema and cracking. So it's pretty gnarly in terms of that, and of course it's a full body rash. It's also known as erythema multiforme major, and if you remember erythema multiforme, it comes in both the major and minor. It has different looks to it, so it's those like can have those just red marks or targetoid lesions. They can have various shapes, hence erythema multiforme, right? Many forms, and so it will look different, but the mucosal involvement tends to suggest Stevens-Johnson syndrome, especially with fever and other systemic signs of illness. If you just have a skin rash, then it's erythema multiforme minor, but Stevens-Johnson syndrome, one of the other hallmarks is that it can go, especially if you have, so if you have something like less than 10% is Stevens-Johnson syndrome, more than 30% is a different process called toxic epidermal necrolysis, or TEN. And that will have one additional thing that we need to talk about. What is the treatment for Stevens-Johnson syndrome? Scary. There isn't one. Now that's now asterisk, because we have found certain things might help Stevens-Johnson syndrome, but the first and foremost, most important thing you always get asked, it'll be on any test you take in med school, anything, is what do you do? The first thing, besides the ABCs, of course, are stop the offending agent. So don't give another dose of Bactrim, or excuse me, Trimethoprim sulfa, or whatever other agent you have that is causing it. Stop that first. And then after that, what do you do? It's largely supportive care, meaning you're giving fluids, you're managing their wounds, you're tending to their skin. There are now some suggestion, people tried steroids that actually made the problem worse. IVIG had small studies which had some minor benefits, others showed some worsening. There is probably a case for biological anti-inflammatories like TNF-alpha and some other of the more modern anti-inflammatories, anti-inflammatory biologics. But still, it's concerning, and you can still progress even despite all your treatments. With TEN, there's one additional thing you have to remember beyond stop the offending agent, because there's so much skin involvement and it's necrosing and you have large areas of skin that's exposed. This is where you might want to think of transfer to a burn center or a facility that has good burn management, because it's essentially like the same process where you have such huge amounts of skin breakdown. You might need specialized care. So that is the one additional thing to think about. All right, what other toxicities do we have to worry about? So we said Stevens-Johnson syndrome, and remember, it is a systemic illness that has mucocutaneous findings, not a rash. That is not your first answer. All right. All right. So another curiosity of trimethoprim sulfa is, let's say you have like a 6-year-old boy. So remember, you hear boy, should raise some red flags, but you have a 6-year-old boy who you're treating has a pen allergy. You've decided, I remember I can possibly use this, and you give him trimethoprim sulfa, and his ear's starting to feel better. But he's pale now, and his urine is kind of dark, and you kind of look at the side of his eye and you notice some yellowing, and so he's got something going on. And what is that thing? What is that thing? That is hemolysis caused by G6 PD deficiency. So just recall, especially when you're, anytime you hear boy, it's usually like a flag on questions. But for reality, right? G6PD is an X chromosome disease, X-linked disease, and so and very common, especially in Middle Eastern, India, Mediterranean climates. Probably because it was a natural defense against malaria, but it also, remember, trimethoprim sulfa is one of those stressors like fava beans and a few other but sulfas do stress it and can lead to a hemolytic crisis in these patients. Let's see, what else? Another sort of common thing that you might see is people want to say like renal toxicity, but it's not actually necessarily the most toxic in terms of nephrotoxicity. But remember, how does creatinine get excreted? Um, about 80 to 90% of it is filtered through the glomerulus, right? You get rid of your creatinine just through filtration, but another additional 10 to 20% is secreted. And so trimethoprim sulfa actually can interfere with it, with the excretion of creatinine at the renal tubule. And so you might actually see an increase in creatinine. It's not necessarily dangerous, especially if you've cut 20% of GFR and your creatinine goes up appropriately to suggest a 20% increase. That's not necessarily dangerous, but it is something that you should be aware of if you put somebody on treatment dose trimethoprim sulfa and they start having an increase in creatinine. Now, if the creatinine on the other hand keeps going up and up and up, and you've got whites in your urine, and of course nobody does stains anymore, but if those stains looked like they were particularly highly binding to eosin, you might think that they have interstitial nephritis. And this can happen, interstitial nephritis and interstitial nephritis can happen with any antibiotic. So it's not really just specific to trimethoprim sulfa, although it is certainly one of the more common instigators in terms of that, penicillin being another one. But just about any medication can be linked to interstitial nephritis, so just be aware of that if your creatinine's really going up. Is there anything else? And then 4, the one that your BMT doctors and onc doctors will fear the most, and that is suppression, bone marrow suppression, marrow suppression. It is, of course, reversible. It's not, it's not a lifelong marrow suppression, but high dose treatment dose for usually a more prolonged period of time, past a week or 2, is when you start to see the marrow suppression. And you're not going to generally see it with pneumocystis prophylaxis. Oh, speaking of which, I had forgotten to talk about that. So, pneumocystis prophylaxis. When else might you use trimethoprim sulfa? Well, in pneumocystis prophylaxis. So, pneumocystis, formerly Corynea, now Jorivici, but still referred to as PCP for pneumocystis pneumonia. What is pneumocystis? And you're thinking, okay, well, it's probably a bacteria, right? I mean, trimethoprim sulfa works it, but it's actually in the kingdom of fungi. And why does that work? Well, it turns out that, just through evolution, fungi, even though they're eukaryotes and we're eukaryotes, they do have, request, pneumocystis in particular is a little bit of a strange one. It doesn't have the same ergosterol cell wall, highly ergosterol membrane, but it does require its own production of folic acid. And because of evolutionary changes, it is trimethoprim sulfa is able to bind to the same enzymes that are being blocked in bacteria and inhibit folate production. And so PCP pneumocystis will in fact be inhibited by it, and that's why we use it for pneumocystis prophylaxis. Interestingly, human do have a dihydrofolate reductase. We have to also, once we have folate, we have to reduce it for it to be useful to us. And if you give trimethoprim sulfa in high enough doses, you can, it's about 1,000 times less binding of mammalian or animal of the DHFR to trimethoprim, but if you give a high enough dose, you can start to actually inhibit that and actually block folate synthesis even in humans, because remember, eventually there is homology between us and that, especially in critical cell functions. And so you will see some inhibition there because it can bind. All right. And I think that's pretty good. So that is trimethoprim sulfa.